Okay, so today we're going to start talking about renal, which refers to the kidneys. Nephro also refers to kidneys. And we're going to start with fluid management because that's a big job of the kidneys, and filtration, which is the first part of cleaning your blood. So the kidneys are part of the urinary system, so their job is to make the urine. So they're filtering blood, and that's what sort of becomes the urine. So it goes through, it filters the blood, and then the good parts are left to become urine, and the good parts are taken back up into the body, and the bad parts are excreted as urine. So it enters the kidney. So blood enters the kidney through the left and right renal artery, renal arteries, and they branch off of the descending abdominal aorta. So the kidney has an outer cortex and an inner medulla, like we see with a lot of organ structures. So the outer part is always the cortex, the inner part is always the medulla. And blood exits the kidneys through the renal veins. So it comes in, blood is filtered, and then you have some that is urine. So urine exits through that ureter, and then any blood that's left over just exits as through the vein and then goes back and is reoxygenated. So then you have just the movement of the urine from the ureter, from the kidneys, it goes into the ureters, and then from the ureters it's stored in the bladder. We already talked about micturition and the urination process, and then it exits through the urethra. All right, so we got to know all that, big picture. So renal functions: regulation of water, electrolyte, acid-base balance. So we're going to spend a lot of time talking about kind of acid-base handling because that's important. We learned that the lungs actually control some acid-base reactions. So we're going to see what the kidneys do. So removal of metabolic waste products from the blood, excretion into urine, certain drugs, metabolites, foreign chemicals. So a lot of stuff is broken down by the liver and excreted that way in the intestines. A lot of it is excreted in the urine and kind of moves through the kidneys. So we have a couple of ways to get rid of waste. So gluconeogenesis, that's also mostly done by the liver, but there is, I don't know, it depends on what you read, anywhere from 20 to 40% of gluconeogenesis occurs in the kidneys. So gluco means glucose, neo means new, and genus means new production or creation. So you create new glucose. That's what gluconeogenesis means. So it's production of new glucose in the renal cortex from simpler ingredients, products. All right, so erythropoietin controls erythrocyte production. This is a very common question that comes up on exams because it doesn't seem intuitive, and so I guess we want you to remember that erythropoietin is made in the kidneys, because you're like, I mean, it doesn't make sense. It's like, why are the kidneys controlling blood cell production? But they do, and a lot of times with kidney failure, you can it's a lot of times associated with anemia, because if you're not producing erythropoietin, then it's not triggering the bone marrow to make erythrocytes, and erythrocytes are red blood cells. Okay, so that's a reduction of oxygen carrying capacity. Okay, so renin, we kind of talked about that with the RAA system, the renin-angiotensin and aldosterone system. And that kind of influences blood pressure, sodium balance. The kidneys do other things. Parathyroid hormone has a lot of activity there. Conversion of 25-hydroxyvitamin D, which influences calcium balance. So a lot of stuff is done in the kidneys, and we're going to get to all of it. But first, let's talk about the basic concept of body fluid distribution. So we already kind of talked about how much fluid is, or how much water is in the body. So it's about 45 to 70%, depends on your age, depends on your sex, depends on, your body type. If you've got more fat, if you don't have as much, that all kind of affects how much fluid or water is in your body. Also health, people who with we have different distributions and different abilities to get rid of fluid. All right, so most body fluid is inside the cells. Okay, so that's an important point to remember. About 2/3 of the fluid that's inside of your body right now are inside of cells. That's, about 2/3, but it's well over half. And we can kind of see that up here in a picture. And the remaining third is extracellular. So that's outside of cells. And so we say interstitial fluid is between the cells. So if we have a bunch of cells, then the fluid, inside obviously is intracellular. And the fluid that's kind of moving between those cells, we call that interstitial, or in the tissues, or between the tissues. And then the remaining third is plasma. So we know that we have blood pumping around in our body. And so there's a liquid part of that, and then there are the red blood cells and other cells that are in that fluid part. And that fluid part is the plasma. So that's about 1/3 of our extracellular fluid. So and then, yeah. So if we look at what our blood is made of, okay, so when we bleed, it's liquid, but really it's liquid with a bunch of cells in it. So the plasma is that fluid, and that's about 55% of blood volume is just the fluid part. If you take a centrifuge and you spin it down, then you'll see that you have red blood cells and some white blood cells that go to the bottom of the tube when you spin it, and then the plasma part stays at the top. So yeah, you would see these packed cells down here. That's your red blood cells, and then you might see like a little layer on top of that with some white blood cells. But then above that, you're going to see the plasma, and that's really, the plasma makes up really kind of most of it. So it's kind of more of a yellow colored, okay, like urine. Okay, so that's kind of how it splits out when you separate blood. Okay. All right. So we already said that the liquid part is the plasma, and then we call these packs there. I should have made that red. We call those packed red blood cells. We call that hematocrit. So the hematocrit is the proportion of blood that is made of red blood cells, and that's usually a little less than half, about 40 to 45%. Depends on the person. There, we made it red because it's red blood cells. And I put a fun fact down here. Hematocrit is usually about 3 times hemoglobin. So when you look at hemoglobin results, and you see that the hemoglobin is, I don't know, we can say, make it easy on ourselves and say it's 15, then you can expect a hematocrit of 45%. Okay. Hemoglobin of 15 is a pretty high hemoglobin. Okay. So fluid shifts. So let's talk about what happens to fluid. When we're talking about shifting here, we're talking about shifting from inside the cell to outside, or outside the cell to inside. So this can be red blood cells, that's included too, but it can be liver cells, skin cells, brain cells. It can be all of the cells. And we've already kind of discussed some things that happen, like when someone is dehydrated, or their sodium is very low, or their sodium is very high. We've already kind of discussed what happens with fluid shifts. If you have a lot of salt outside the cell and not as much inside the cell, then you're going to have a shift to the higher salt concentration. Okay, so that's just when we learned about osmosis. That's a fluid shift. If we have a lot of salt outside, it's going to move out. The water is. If we have a lot of salt or particles inside, then the fluid will move in. So it moves to where the particles are. So these are what we call osmotically active particles. Osmotically active means that it can't just. So if you have something here and you have a bunch of particles inside the cell, okay, if this is a cell over here, osmotically active means those cannot just filtrate through, okay? So they can't just move right through the membrane. So they may be trying to, because you may have really low concentration here. So those particles that are built up inside that cell may want to move out, but they can't, okay? So that's what makes them osmotically active. And the reason we say that is because the only other option now is for water to move in. Okay? So that's going to pull the water in, and that cell is going to expand. Okay? Okay, because it's trying to match the concentration of particles inside or outside too. So it's trying to get the same concentration inside and outside, and the only way it can do it if they are osmotically active, which means non-penetrating, it can't get through that membrane, the only way they can do it is to pull water in. Okay, and so then that's going to spread them out, and maybe they'll be at the same concentration at some point. Okay, so that's what we talk about with fluid shifts, is we're shifting water either inside to the inside of cells or outside of the cells. Okay, so osmolarity is that concentration of particles in fluid. Okay, so you can have an internal osmolarity, external osmolarity from cells, but really when we talk about osmolarity, we're talking about the osmolarity, the overall osmolarity in the body, whether it's interstitial, in the blood, and usually what we measure is we measure it in the blood, and it's usually about 300. So we could say 290 to 300 milliosmoles per liter. Okay, osmolarity is milliosmoles per liter. So that's normal, about 290 to 300. High osmolarity, if you hear something being high osmolarity, that can, I don't know, it's not really that confusing if you learn it right the first time, but high osmolarity means that it's got a lot of salts in it, a lot of particles. It's high osmolarity, and it can get up to like 1100, like in really, really concentrated urine, can be really high, 1100 to 1200 milliosmoles per liter. So that's high osmolarity. Low osmolarity, so even though it's at about 290 in the blood, you can drop it down, you know, way lower, okay? 200, 180, you know, that kind of thing. And that's low osmolarity. So we talk about hyperosmotic contraction or expansion. So if we just think about that, hyperosmotic contraction, so addition of high salts, so that would be actually an expansion, and addition of high salts can increase the movement, can cause the movement of cells outside. Let me shut my volume off. So if you have a expansion, okay, expansion means that you are increasing fluid. So this is on the bottom here, we can see volume expansion. And unfortunately in this bullet here, the example, it's not a bullet, but the examples are just, these are both examples of expansion. So addition of high salts or osmotic particles can cause a shift of fluid from inside to outside. So we have this expansion that takes place here, high salt intake, and it's going to cause the movement of fluid from the intracellular, and see you leave a little gap here, okay, so it was full, okay, and then and so it moves to the extracellular, and we have an overall expansion. So overall expansion means you have more fluid in the in your extracellular space. So you have more fluid outside the cells. Now, that's always going to be the case with an expansion. So you can see that if you started out here in this case, just with the box filled in correctly, what you see here is you see a little bit extra. Okay, so that's your expansion. That's the additional fluid, okay, that was added. A contraction means that you've lost fluid in your extracellular portion, fraction. Okay, so all of these you can see for contraction you've lost, and expansion you've gained. So now we'll talk about hyperosmotic contraction and expansion, and it really has to do with salts. So what has happened to the salts? Have we lost salts, which is maybe the case if we're sweating too much. We lose salts, and then we have this contraction. Fluid is kind of moving, is decreasing. All right, so we're going to talk in detail about all of that stuff. Okay, and I put this note down here. Oh, in isoosmotic, you don't have any shift. You don't have any fluid shift. Okay. So I put this note down here that volume contraction will always result in lower extracellular fluid, and expansion will always result in higher extracellular fluid. That's where we get our expansion and contraction from. And I say the question is whether or not a fluid shift has occurred. Do we have any movement from the inside or to the inside of the cell? Okay. Because these little things can be kind of confusing. So consider the effect of osmolarity and fluid shift. Also think about things like hematocrit. So we remember our hematocrit was the proportion of red blood cells if we spin it down. But if you think about that being in the blood, how much of the blood is made up of red blood cells? Well, if you lose a lot of fluid, okay, if the fluid goes away, then what happens is that you have a higher proportion of red blood cells. Okay, if you lose that fluid and it doesn't, and those cells remain the same size. And the same thing with protein, pretty much. The difference between protein and red blood cells, though, is red blood cells will absorb or lose water. Meanwhile, proteins are just there. So if you have a volume contraction where you have less volume and you just had a certain amount of proteins, by losing volume, you're going to have a higher protein concentration. Right? Now, that may not be the case with red blood cells, because red blood cells, if you have fluid moving out of the cells, okay, you're losing fluid overall, but you also have fluid moving out of the cells, well, then those cells are going to shrink, and so you may end up with the same hematocrit. That makes sense. Just because the cells are smaller, yes, your fluid volume may be decreasing, but your cells are also getting smaller. So your overall fluid volume will change, but your hematocrit can stay the same, and we'll kind of talk about that. Okay, so let's look at some examples that are listed here. We'll try to go through these kind of quickly, but it's kind of, I don't know, we don't want to gloss over it too much. So isoosmotic volume contraction. So the idea here is with diarrhea, you lose fluid, but you also lose some salts or some particles. So your overall change in fluid is isotonic. So if your fluid, let's say, is 300 milliosmoles per liter, and what you're losing in diarrhea is the same concentration, then that's you're losing. It's isotonic. So what you're losing is the same concentration of what you already had in your body. The reason that's important is because there won't be any fluid shift. Right? So whatever's leaving is leaving, but it doesn't mean that you're either increasing or decreasing the salt concentration of what's left behind. So yes, a lot of fluid leaves your body with diarrhea, but what's left is the same concentration, so you don't have a shift of fluid one way or the other. Okay? Now, if and this is just a hypothetical, if when you had diarrhea you just lost water and all your salt stayed behind, then you would end up with a high salt concentration left behind. But that's not the case. It's isoosmotic, and so there is no fluid shift. However, you can see it's a volume contraction. So we are losing volume, so our extracellular volume has decreased. So you can see this little space here. That's the decrease of volume. And it's extracellular. Intracellular doesn't get involved because it's isotonic. Okay. All right. So our example, the next example here is water deprivation. So the thing to remember with water deprivation is, okay, let's say you're out hiking and it's 100 degrees out or more, and you didn't bring enough water with you. Okay, so you're sweating, and the thing to remember, this is what I was going to say about sweat, is it's mostly water. Okay. So you're losing mostly water. Yes, we all know, or we should all know, that there is some salt in sweat, but it's not as much as you have in your blood. Okay, so so you're losing more water and you're leaving behind salt. So this is what you need to understand, is that if you have, so if these are cells, okay, and you have an increase in salt that's left behind because water is going away, but that means our salt concentration, extracellular, is increasing. It's a fluid contraction. You're losing fluid, so our extracellular fluid is going down. Okay, that's going away. But now what starts to happen is we have fluid that's going to move out of intracellular, out of the cells, and into the extracellular fluid. Okay, so fluid's moving out of these cells, okay, which means that we're going to have less here. Okay, so we can see this space over here, which means that we've lost fluid from inside the cells. Now, overall, okay, so one more component to this. Overall, we've increased our osmolarity because we're losing water, and yes, there is some salt in it, but we can just say we're losing water overall, and we're leaving behind salt. So that means our osmolarity is going to increase. It's becoming saltier. Okay? And when we say salt, it's usually salt particles. In this case, it would definitely be sodium chloride salts. Okay? So that kind of explains all of these things. We have a fluid shift from inside the cells to outside. Okay? We have an overall volume contraction, okay, which we see in our extracellular, and we have an increase in tonicity, or we have an increase in osmolarity. Okay, so it's becoming more higher osmolarity, hyperosmotic. Okay. Let's see. So let's go through the next one, and the next one's going to be just the opposite. Okay, so let's see if we can go through this a little more quickly. And we're saying adrenal insufficiency. So first of all, we have to remember the adrenal gland sits on top of the kidney. Okay, and one of the things that it releases from the cortex, remember in the medulla we were releasing things like, well, cortisol, we haven't learned about that yet, but we were releasing things like epinephrine. But out here, it's a little more finesse, and we release aldosterone. Now, if you remember, one of the things that aldosterone does, actually in the kidney, is it causes you to reabsorb more sodium, and chloride follows sodium. So it's causing you to keep inside your body sodium chloride. All right? And that's going to keep us at that 300. Because this is normal. That's normally what it's supposed to do. Okay? Keeps us at that 300. Now, what if the adrenal glands stopped working? Ooh, my kidney just went away. That's not good. Our adrenal glands stopped working, and we stopped making aldosterone. Then we're also going to stop reabsorbing sodium, and we're going to lose that sodium in urine. So we now have sodium in the urine. Sorry, I'm writing over things, but that's what we're talking about. So let's just say this in a simple way. If you have adrenal insufficiency, you're dumping sodium out of your body, and your what's left behind is going to be much more watery, much more dilute. So let's address that first. We've lost the sodium, which means that our osmolarity is going down. We're going to have decreased osmolarity, because the lower osmolarity means more dilute, or if you want to say more watery, that's fine. So it's more dilute, but also because there's less salt in the body, or in the extracellular fluid, because that's what we're talking about, okay? Then we're going to have a fluid shift, because now, according to the cells in your body, fluid is shifting fluid is going to shift into the cells, and they're going to, you're going to have more fluid inside the cells. Okay, because it's less salty outside, because your aldosterone is not preserving the salt, and so your salt is being urinated out, and so it pulls that fluid. So you have a fluid shift from the extracellular to the intracellular. Okay. So let's look at, so those were our volume contraction examples. Okay. So let's look at our volume expansion. So we're going to have a lot of these things again are going to just be the opposite, except in the case of the first one, it's kind of the opposite. There is no fluid shift for isotonic sodium chloride. So you've given somebody a drip. This is kind of not funny, but a lot of this happens sometimes, in that we have patients that try not to do this, but are started on a saline drip when they first get to the hospital or whatever. They're put on a continuous IV infusion of sodium chloride and are forgotten about. Okay, so it's just kind of going and going and going. And what happens is that there is no fluid shift because it is isotonic. Okay, so there's no overall fluid shift. It's the same concentration inside the cells as outside. So water's not trying to move, but you do have more and more fluid building up in the body. So it's going to be extracellular, and so that's what we see here. We see the extracellular increase in fluid. Okay. All right. So let's go the other way. High salt diet. Okay, high salt. And what do we have? Let's see if we have our salt shaker here. That's a salt shaker. And what do we like with salt? We like to drink. Okay. So we have just by eating a high salt diet, what happens is we tend to preserve and conserve and keep water inside the body. So if we're keeping water inside the body, little by little, we're going to have increased volume. Okay? And we see that our extracellular fluid volume is increasing. We're also keeping salt inside the body, so our tonicity is going to go up. So we are getting higher osmolarity, so hyperosmotic. And because we have high salt and it's going to be in the extracellular fluid, we have a shift. So now our little cells here are saying, wow, this dude really likes salt. And so you're going to have a fluid shift from intracellular to extracellular. And that's what we see here. We see this loss of fluid inside the cell, and it shifts to the extracellular. Okay? And then, so our last example is something called SIADH, or Syndrome of Inappropriate Antidiuretic Hormone. And that just means that the pituitary gland, the posterior pituitary gland, is going to release a whole lot of ADH, antidiuretic hormone. And what antidiuretic hormone does is it causes you to reabsorb a whole lot of water. Okay? It's important to know, it's important to keep in mind that ADH only affects water, pretty much. Okay, so it's not like aldosterone, which is sodium chloride and then water is following it. This is opening up aquaporins and saying we are reabsorbing and keeping in the body more water. Okay, so we already see that if we're keeping more water in the body, that we're going to have more volume. And we can see that with our extracellular fluid. We see more volume. Okay, so we've already kind of checked that off the list. The other thing we look at is if we say, okay, well, if we're keeping more water, our osmolarity is going to go down. And we see that. Osmolarity has decreased overall. And then we say, okay, but if we're keeping water but not salt, then what we're doing is we're just diluting. Yes, our extracellular fluid is increasing, but we're diluting it. Okay? So we're going to see a shift of water to the intracellular. So water is going to move into cells, and that's what we see over here. As we see increased intracellular volume. Okay, so hopefully that makes sense. I have a chart here that kind of talks about these things. Let's see, sweating. So we just kind of went through all of these for sure. We covered them. We didn't really cover the hematocrit. You can see that, and I'll go back just for that in just a second. But first I want to say this about plasma proteins. You can see that if you lose volume, if you have all of these are contraction. So if you lose volume, then your protein's going to go up. So that's just like saying we have this many protein in this much volume, and then we decrease the volume, but we have the same amount of protein. So our concentration of protein is going to go up. Okay. Now, if we look here though, and we say, okay, when we sweat, our hematocrit has no change. So why, when we sweat, does our hematocrit have no change? And where is our water deprivation? So let's just look at our cells. In this case, we're going to look at our blood cells, red blood cells. And we're going to say, okay, we have water deprivation, which means we're losing water, okay? We're losing water overall, so we see that shift. And we're saying that we're leaving behind salt, so we have higher salt out here. Okay. So we have a reduction in overall, this is the difficult part, we see a reduction in overall fluid, and we say, well, if we see a reduction in fluid and we have red blood cells in here, then our red blood cell number isn't changing. Shouldn't our red blood cells make up now more? Shouldn't our hematocrit increase? Because our proportion of red blood cells is going to be higher because our fluid is going away. But the thing that's interesting about red blood cells is that they get smaller in this kind of a situation. So there's a fluid shift of fluid out of the red blood cells, and they shrink. So you may have the same number. You may have the same number of red blood cells, but because they're smaller, they're taking up the same proportion. Okay, so yes, less fluid and smaller red blood cells. Okay, so your hematocrit does not change, and that's only because of the property that blood cells can absorb, or water can move into or out of red blood cells. That's not the case with proteins. That's why it's easy with proteins. Less water, higher concentration of proteins. But yeah, we have this ability of red blood cells to kind of move, change size. Okay, that took a while, and I knew it would. So let's kind of go through, let's see, what have I done? Let's go through and talk about, and then talk about filtration. So kidney anatomy and vascularization. So I just wanted to put this in here. It's a picture. It shows the abdominal aorta, and it shows the, I think it does, yeah, the abdominal aorta here, and it shows the kidneys getting a blood supply for each. Okay. So each kidney gets its own blood supply from the arteries, and I wanted to say that kidneys are retroperitoneal. This is kind of a big deal, something to talk about, but they are behind the peritoneal cavity. So most of your other guts are inside the peritoneal cavity. The kidneys are behind that, so they're kind of in the back. Okay. So some of the parts of the kidney you have, of course, we already talked about the cortex and the medulla, but there are these structures that kind of show up in the medulla, and this is nephrons that are kind of pushing down in this way, and so it's kind of divided into these sections, and you have these things called the renal pyramids. Okay, so we have nephrons that are kind of moving into those, and they cause these pyramid structures to form. Well, then fluid, urine, it's actually literally urine almost now, is moving from those and down into these things called calyces. So we have the major calyx and the minor calyx, and those are just, you know, portions of the same thing, the minor, and then it kind of comes together to form the major calyx or calyces. So we have the minor, the major, and then those will drain into the renal pelvis, okay, and then that all exits through the ureter. Okay, so so these little lines I drew, those are nephrons. We'll have better pictures of them, but nephrons dipping into the medulla from the cortex. Filtered blood moves through the major and minor calyx into the renal pelvis, out into the urine and into the ureter as urine. And another thing that we're going to remember, or we're going to address later, is that the concentration deeper in the medulla is much higher than the concentration out here. Okay, so it's much more dilute out here. Just keep that in the back of your mind, and that's going to make sense when we start talking about collecting ducts and concentrating urine. Okay. There, I erased all that beautiful artwork. Okay, so blood supply. So on average, we talked about this before too. Kidneys constitute, when we talked about parallel flow, Kidneys constitute less than 0.5% of total body mass, but they receive 20 to 25% of resting cardiac output. I hope that's, I mean, that's surprising and impressive, I think, but it makes sense because the job of the kidneys is to filter blood. So of course blood's going to have to move in there. So 20 to 25% of cardiac output goes to the kidneys to be filtered. So you got the left and right. And then we're going to say this so many times, but this is the first time I'm saying it here, is that blood, after it leaves or after it branches from the renal artery, okay, it branches into an arterial. So that's pretty common. We're used to that. So arteries branch off and become smaller, and they turn into arterioles. And so we have that. We have arterioles. And the arterial is what will feed into something called a glomerulus, which a glomerulus is just this web or ball of capillaries. Okay, and so this is where filtration is going to take place. And so this is where blood kind of gets squeezed, and the fluid parts will go into the nephron. Okay, this is the nephron, or the nephron tubule, and red blood cells, bigger proteins, stuff like that will just continue out of the efferent arteriole. So we have an afferent going into the glomerulus, or the Bowman's capsule, which includes the capsule around it, and the whole thing is called a corpuscle. But so we have blood that moves into the glomerulus, and then filtration takes place. It kind of squeezes that blood out, or doesn't, you know. We'll see how that control takes place. And then the blood, that's whatever's left, will come back out through the efferent arteriole. So we have movement, in this case, from an arterial to a capillary, and we learned before that it goes then capillary to venule, but that's different here because all we're doing is trying to filter the blood. So we have just this capillary ball here, and then we go back to efferent arterial because we haven't lost oxygen. Okay, so we haven't deoxygenated anything at this point. We haven't given that we haven't given the oxygen to cells, so it's still the same oxygenation. We're just filtering some stuff out of it. Okay. All right. So it goes. So that's unique because it goes arterial, capillary, and then back to an arterial, and then later on it'll start, you know, feeding the kidney and giving up its oxygen. Okay, so there are about 1 million of these nephrons in each kidney, and really, I say these are the kidneys, so that is what makes up the kidney kind of structurally and functionally. Okay, so let's look again at this. So we have our efferent arterial. I don't know which is which here. We have the Bowman's capsule, which has the glomerulus inside it, the little capillary ball. Okay, and then the renal tubule. So this picture shows the renal tubule. So there's the proximal tubule, or the proximal convoluted tubule. It's called convoluted because it twists around, and somebody said, wow, that's really convoluted. And so now it's the proximal convoluted tubule. It's proximal because it's early, and then that will go down into this loop that we call the loop of Henle. Okay? So we have the descending limb of the loop of Henle, the ascending limb of the loop of Henle, and then that will then turn into the distal convoluted tubule that twists around, and then that distal convoluted tubule will move and turn into the collecting duct, and then the collecting duct will drain that urine like we saw down into the calyces and the pelvis, and then out through the ureter. Okay, so that's the pathway. So we have to know the pathway, and we're going to talk about so many details of the pathway that I think you won't be able to not learn the pathway very, very well, which is always fun because it's still fun to give a test question about what's the pathway, and hopefully that'll be an easy question for you. Okay, so now look at this structure, but this is not the way nephrons look. Okay, that's not the way they look. This is more accurate over here as to how they look. See how our capillary ball isn't over here facing this way? It is actually, and here's our afferent and efferent arteriole. See those guys? They're actually in contact with the distal tubule. So fluid, blood is moving in here, filtered, and then it goes down into the descending limb, ascending limb of the loop of Henle, distal tubule, and that way we can have checks on what is happening with blood flow here. So we're looking at two things. Two things are checked here in slightly different ways. One is pressure in the arterioles. Okay, so that's being measured. And then also we have how much salt, sodium chloride, is in the tubule. And then we can kind of adjust how fast we want things to move through the tubule. So this right here is structured this way as feedback. So there's sensing that happens saying, okay, how fast is salt, sodium and chloride, how fast are they moving through? Do we need to slow it down? Do we need to speed it up? And then it's how much do we have to adjust the movement of blood through there. Okay. So another picture kind of showing the same thing, but everything here is labeled. Now this does have like the thin section and the thick section. So we have the thick part of the limb, of the descending limb, and then it kind of gets thin. And really what happens with the thin part is really water is taken out here, and then salts are taken out on this side. Okay, so you've just got some specificity, and we'll go over in detail what's going on. But then after those salts are taken out, and then it starts to become more dilute again. So you have fluid. There's a lot of fluid in here, and then that hydrogen leaves, or sorry, the water leaves, H2O leaves, and then it's like, okay, well now all the water's gone. It's really salty down here, and then the salts can go, okay? And then it gets watery again, and that's why we have the thick and the thin. Okay? And that'll make more sense when we actually talk about reabsorption and all of those details. Okay, so two different types of nephrons overall. Juxtamedullary. Juxtamedullary, the key word here is medulla. Okay, so long, they have a very long loop of Henle that kind of dips down into the medulla. Okay, so long loop of Henle involved in concentration of urine. So we were just talking about how water moves out of here. Most of the water and nutrients move out right away in the proximal tubule. And salts and glucose, most of that stuff moves out right away. But then you have water that moves out in the descending limb, okay, and gets thinner. So as it does that, so longer means that you're getting it more and more concentrated. You're squeezing more water out, and then of course the salts are going to go here. All right. And so that concentration difference is very important, that it's highly concentrated here and less concentrated up there, because you've got stuff moving in and out of these tubules. Okay, and then you have a lot of filtration, just kind of cleaning things up and putting it back into the body. That happens in the cortical nephrons, so these tend to be more in the cortex, a bit into the medulla. They don't reach as far as they don't juxtapose into the medulla as far as the juxtamedullary nephrons do, okay, because they are cortical. Okay. All right, so glomerular filtration rate. So that's a big deal. It's a very big deal. So how quickly are things, so this is our glomerulus, remember, the little capillary ball. So the question is, how quickly are things being filtered through here? So we can say that we want to really filter stuff really, really fast, but you know, maybe that's not as, you're not filtering things as well. If you're filtering fast, maybe you're losing more urine. So we need to keep a really close eye on our glomerular filtration rate. We want that rate to be consistent. We want it to be consistent even if blood pressure is varying, okay? So we have to have a way to control it, and there is an internal control or a local control that happens. So we want it to be the same over a range of blood pressures, but we also want to make sure we're filtering things properly, and that we're not just rushing it through and we're losing a lot of salt in our body and more urine's not being lost, that kind of thing. We want to give the nephrons a chance to reabsorb the nutrients that they need to reabsorb. So we're going to monitor mainly those two things to make sure that things are getting filtered properly. Okay, so Our average urine production per day. Oh, so the glomerular filtration rate. This glomerulus is very, very fine tuned to filtering and letting things through. So it can really let things through quickly. So it's 180 liters per day. And if you think that, we have about, I don't know, 5 or so liters of blood in our body, and 180 liters per day is filtered just through the kidneys. We're constantly filtering. That's why having kidneys is so important. Is we're constantly trying to keep our blood clean through these kidneys. So out of that 180 liters a day of blood that's moving through there is filtered, or filtrate that's moving through the nephrons. Our average urine production is only 1 to 2 liters. Okay, so most of that is reabsorbed. Okay, so what I was kind of talking about in the previous slide, and we'll talk way more about later, is that most of that is reabsorbed. And it has to be, otherwise, 180 liters, you can't even drink that much in a day. You would just lose all of your blood in, like, I don't know, a couple of minutes if you weren't able to reabsorb that. So the pressure difference forces filtrate across the membrane. So how does this filter? So here's our, let's say, I hope I don't do this wrong. Here's our afferent. We're just going to kind of arbitrarily name this. We're going to say that blood is moving through here, and so it's under pressure. Okay, so we can see that pressure is going to push it through there. Okay? We're going to look at the structure of how that happens. There are little holes in there, fenestration, that allow the water to move through, and small things that are dissolved in it. But when you're pushing a bunch of fluid into something that's kind of building up or is kind of coming together, converging, you're going to have a little bit of back pressure. Okay, so you're going to have, so yes, we've got mostly blood pressure pushing it in. Okay. So big line saying blood pressure is pushing it in, but you've got a little bit of back pressure. Okay. Now the other thing is that there's nothing in here that there aren't any proteins that are in here that weren't already in the blood. So we're pushing a bunch of filtrate through. Okay? So there are some salts and stuff that are moving in, but they're not really pulling the fluid in. However, what we're leaving behind, so if we can draw kind of what's going on in the nephron, so we have red blood cells and white blood cells, a whole lot of proteins, so those are what we like to refer to sometimes as colloids. Okay, so we've got a lot of proteins, and those proteins in blood cells, they're not allowed to go out. So what happens is you have fluid moving out, and these are all staying behind, and so that's going to cause a pull back. Okay, so because this is going to be mostly fluid, and this has a lot of salts left over. So yeah, the fluid is going up, then they're like, wait a minute, it's a lot saltier, there are a lot more particles in there, mostly because of proteins. One protein we talk about is albumin, but like I said, there are lots of proteins. There are, your immune proteins, immunoglobulins, other kinds of, globular proteins. You've got your clotting factors. You have a lot of other types of factors that are in your blood. So yeah, that's going to kind of pull back. And so the fluid is being pushed out by hydrostatic, with a little bit of pushback from hydrostatic from the Bowman's capsule. But the real pull back in is going to be that oncotic. Okay, so we have an oncotic pressure pushing back. So let's get rid of all that stuff, even though it's really not very visible. So this is our hydrostatic pressure saying, hey, let me in. We've got a small bit of back pressure pushing back, hydrostatic pressure pushing back. And we have, it depends on what's going on, but we have colloidal pressure also pulling back because of those proteins that are left in the vessel. But overall, we want to have positive filtration. So filtration is going to be happening, okay? Unless we've lost so much water in here that we have so many proteins left that this matches, okay, which happens. Okay, so hydrostatic and oncotic pressures keep fluid flowing into the Bowman's capsule, and then they move into the proximal convoluted tubule or proximal tubule, and they go on to find out if they get to be urine. Okay. Okay, so So overall, so we just mentioned filtration. We're going to go into more filtration, but just so we know what's happening here. So if that filtration kind of moves into that proximal tubule, and then we already said that there's so much 180 liters that's moving in there that we have to have a lot of it reabsorbed. Okay. Now we also know that, and so that's going to move right into the capillaries that just left the glomerulus. Okay, so a lot of that stuff's moving back, so it's going to move right back into the vessel. It's almost like nothing ever happened. Okay. Now we also know that not everything is filtered, so everything doesn't move through the glomerulus and into the nephron. Some of it just keeps going. Okay? So the body has ways of kind of selectively looking at like organic molecules that maybe shouldn't be in the body. Okay, so there are reactions, there are transporters that will see some of these things and swoop them up and say, nope, you got past us, you didn't get filtered in, but you're coming in anyway. And that's what we call secretion. Okay. So secretion is always kind of out of the body, and this is the case here too. It's being secreted because the urine is basically, this is just a hole outside the body. So we call that secretion. So a lot of stuff is reabsorbed, some of it is secreted, and then that can be moved back in. So secretion can happen in a couple places: proximal tubule, distal tubule, and even some can happen in the collecting ducts over here. Okay, but that's what we're talking about. That's our big picture. We're going to go through each of these individually. We're going to start right now in a second with filtration. And then we have reabsorption, movement from the tubule to the blood, secretion, and then getting rid of it is excretion. Okay. All right, so let's talk about that control that we kind of alluded to earlier. So juxtaglomerular apparatus and control of renal blood flow. So you have pressure sensors. So we had talked about stretch receptors, which are mechanoreceptors before. So in the arterial wall, so here we can see them here. In the afferent arterial, there are stretch receptors that say, okay, how fast or how much are we going to constrict, or are we going to dilate? Are we going to let more, or are we going to cut off blood, or are we going to let more blood in? Okay. So in the arterial wall, juxtaglomerular cells are enlarged smooth muscle cells that contain the hormone renin. Okay, so this is, remember when we talked about renin, which turns out angiotensinogen into angiotensin 1. So renin is contained in those, so they can activate the RAA system to increase blood pressures, but they are mechanoreceptors, so they are detecting the stretch. Okay, so they sense that blood pressure and they say, okay, there's a lot of blood. This person's blood pressure is really, really high. They must have a test coming up, and so we need to kind of constrict that and reduce that. Okay, so that's what they do. I have this written on another slide. Didn't have room on this one, but that's what these JG cells do. Is when they stretch, and then they will cause contraction, adenosine. Okay, so the macula densa is another group here. Okay, so it says the tall, closely packed cells. So these are the tall, closely packed cells here. So remember, we said that the distal tubule moves up past the afferent and efferent arterial, and you can see these macula densa cells are right there. And so what can happen? What can happen is that sodium chloride can move across. Let's see. No, kind of. They're going to, so sodium chloride is in here. And this can determine the concentration of sodium chloride, and it can have an effect on blood flow into the it can have an effect on blood flow into the nephron. So it's going to slow. If you have a lot of salt, then it's saying, okay, things are moving through very, very quickly. This person, I mean, this is the distal tubule. This is just one step away from turning into urine. If you have a high salt concentration, then your kidneys might want to be like, okay, we should probably slow things down. So there's going to be some vasoconstriction, especially in the afferent arterial, okay, which will slow blood flow when slowing blood flow will slow filtration. Okay, so I just went back to slide. I always forget this. So Fick's law states that the amount of substance entering an organ equals the amount of substance leaving an organ. So this includes fluid, plasma, electrolytes, proteins, etc. So let's apply this here. Okay, and if we say, so this is our afferent arterial, and we say, hey, there's a whole lot of stuff. Okay, a whole lot of, we'll just say blood moving in here. What it's saying is that if there's more blood moving into this area, then you're going to have more leaving, which means you're going to lose more. Yes, some of it you're going to have more moving through, but you're also going to have more filtered. And if you have more filtered and it's just cranking through these nephrons really, really fast, then what's going to happen is you're going to have increased urine. Okay? So higher pressure going into the glomerulus means higher GFR. So higher pressure means higher GFR, glomerular pressure. Higher GFR, which means increase urine volume. Okay? So all of these things are related, and that's the Fick's law thing. Okay, so increased pressure means increased GFR, glomerular filtration rate, which means increased volume. So then what happens is when we bite down or squeeze down on that afferent arterial, we're slowing blood flow. We're decreasing blood flow, and we're decreasing our capillary pressure in here, our glomerular pressure, which is going to decrease filtration rate, which is going to decrease urine output, which is going to cause better reabsorption, hopefully better if things are working properly. And things should function okay. All right, so together our JG cells are saying just pressure is way too high, trying to keep that at a regular rate. And then your macula densa cells are saying things are moving too fast through here, too fast or too slow, and that's also going to determine how much blood is flowing into the glomerulus, okay, which is going to change the pressure in our GFR, glomerular filtration rate. So same thing. So this is kind of explaining the same thing. So salt regulation, blood flow regulation, the kidneys is locally and metabolically controlled. So I'm going to go through both of these concepts again. So increased glomerular filtration rate, GFR, is influenced by increased renal blood flow. RBF has a couple of meanings apparently. So renal blood flow, and that is what's related to Fick's law. So the increase in sodium and chloride, so this is our macula densa, and macula densa. So the increase is going to trigger the release of adenosine, and adenosine is going to cause constriction of those afferent arterioles. Okay? So it's going to restrict blood flow in, and it's going to slow things down. So high, so that's the, I guess, the hard thing to remember. So if we have a lot of sodium and chloride ions, that probably means things aren't being reabsorbed properly and they're moving through too quickly, so we need to slow it down. Okay? And the way that happens is the release of adenosine. Adenosine causes vasoconstriction. In this case, it causes constriction. Doesn't do that everywhere. And it's going to lower that GFR and that RBF. Okay. So I want to say this first here. The other thing that we already talked about, juxtaglomerular cells are constantly monitoring that blood pressure and adjusting the diameter of the afferent and the efferent arterioles, but the effect is higher on the afferent. Okay, and that's important because of what we're going to start talking about next. So the afferent arterioles are really going to be what controls blood flow in the kidney. So yeah, it has an effect on the efferent, but that's, you know, that's kind of less consequence if we're squeezing down on the afferent more. So if you look here, blood flow. So this is what it's saying. Well, okay, it's kind of what it's saying, but it's concentrating on that afferent. More clamping down on that afferent is going to really decrease your GFR. So fluid is not going to be moved through as quickly. The other option, of course, Oh, there are three other options, but another option is over here and saying, well, what if we leave the afferent arteriole alone and we squeeze on the efferent? Well, that's going to cause a lot of back pressure. So blood is trying to move through and it's like, uh-oh, I can't get through there. I can get through here, and it's going to increase your GFR. So it's going to increase fluid moving through. You're going to have faster, blood's going to move through, or filtrate is going to move through faster. Okay. Meanwhile, if we clamp down on the afferent, it moves through more slowly, which is the macula densa. And the macula densa is like straight up, it's all about the afferent, and it really blocks blood flow. Okay, so that's how the oh, and I have this note here: both afferent and efferent arterioles are controlled by alpha-1 receptors, but there are more on the afferent again side. So our sympathetic response is also to reduce overall blood flow to the kidneys. So that means that sympathetic activation will reduce blood flow and filtration rate, which reduces urine output. Okay, so we have this, I'm just going to say this now. We kind of have this, so if we have a sympathetic response, this will make sense later. I mean, it'll make sense now and later. We have a sympathetic response, and we have reduced blood flow. And sympathetic and the sympathetic constriction can be a lot. And so, but one thing that's important is blood flow to the kidneys. And so if we have heavy sympathetic response, then, and that goes on for too long, then we can actually have kidney damage from that. Because remember, this blood isn't just here to filter, it kind of moves on through and feeds the kidneys. I mean, it gives nutrients to the kidneys. So then what can happen is there's this molecule called prostaglandin, which causes dilation. So the prostaglandin release, now normally prostaglandins are just associated with like inflammation, but in the kidneys they can cause some vasodilation. And so they kind of preserve that GFR. They kind of preserve movement of blood through the kidneys. Okay. So we're going to mention that later when we talk about how things like NSAIDs, which block prostaglandins, can lead to kidney damage. But I just wanted to say it because this is why, because the prostaglandins are kind of helping prevent that sympathetic damage. So it kind of works together. Okay, so let's get back to what we're talking about here. We've got four different situations. So we have constriction of the afferent arteriole, which is just going to block blood flow. Okay, so it's going to slow GFR. We have a situation over here next where we say, okay, let's leave the afferent alone and let's constrict the efferent, and that's going to cause that back pressure, which is going to increase GFR. So we can see the bigger arrow there, small arrow there, big arrow there. And then we say, okay, let's leave the afferent alone and let's just dilate the efferent. Well, then when the blood's going through, it's going to be like, should I get filtered? Oh, look at that giant hole up there. I'm just going to go there. So that's going to keep your GFR low. Okay, so dilating that efferent is going to keep it low because it's going to find that least resistance, and there's like hardly any resistance there. And we have a situation where the blood flow is here and we've dilated the afferent arteriole. So we're saying, hey, blood, it's like a sale day at Walmart. It's like, hey, everybody come in, and because I don't know, do they have sale days at Walmart? So a lot of blood gets to come in, but then it's like, well, yeah, but you know, the hole to leave isn't as big, so we're gonna have to go through the kidneys. So it's a trick, and now it's all urine, and everybody's life is ruined. Okay, except the person whose functional kidneys are saving them. All right. I promise we're gonna get done with this. Okay, so afferent versus efferent constriction. So this is kind of saying the same thing. Afferent is going to decrease the flow. It's going to decrease GFR. If we only constrict the efferent, it's going to increase GFR. So this is kind of a picture representing the same thing, kind of in a different way. So we don't need to spend a lot of time with this. Renal blood flow and glomerular filtration rate. So it is constant over a distance. I've got a couple of slides that kind of show the same thing. I just showed this one here, which was the couple of slides before, but this is the same concept. And that shows that if blood pressure gets up to, let's see, what is that, about 80, and that's your map, should be your map, then we can see that if a map is at least 80, then, and our blood pressure gets higher and higher and higher, our glomerular filtration rate doesn't change. Okay, and that's because we're, as the blood pressure gets higher, we're squeezing more and more and saying nope, don't come through. Okay, and again, here's that note on prostaglandins and NSAIDs. So the nonsteroidal anti-inflammatory drugs inhibit prostaglandin production. Remember that prostaglandin was causing some of that vasodilation. Okay, so normally these prostaglandins trigger inflammation, but in the kidneys they cause that vasodilation, kind of as that protective mechanism. So, you know, sympathetic, don't have a runaway sympathetic vasoconstriction. I'm oversimplifying there, but that's essentially what they're doing. So if we block that production, then we can cause constriction, or it leads to constriction of the blood vessels. Now, in a healthy person, no big deal. Okay, but overuse or chronic use continued can start to cause kidney problems. Okay, can also start to cause bleeding problems. Okay, so NSAIDs are fine in moderation, like everything. Okay, but that's why NSAIDs can be nephrotoxic. Okay. So a couple of details, just kind of some things we need to talk about, kind of the details of how filtration takes place. They're associated with two sets of capillaries, the glomerular and the peritubular. We talked about that. Glomerular capillaries specialized for filtration. Okay, so those little details like arterial to capillary and then back to arterial, that's the only place that this takes place. So that's our glomerulus, okay, glomerular capillaries. But then we also have peritubular capillaries. Peritubular capillaries, so as things move past, so they go through the glomerulus, some of it is filtered, some of it continues. And so what happens is that this can be used to sort of feed the cells of the kidney. Okay, so I mean, all of these things are made up of cells, right? I mean, your whole tubules are made up of cells. And so those cells need a blood supply. And so we have to get nutrients in the kidney. So most of the filtrate is reabsorbed and returned to the blood through these capillaries that are surrounding the tubules. The peritubular capillaries are important for exchange. So we also saw that we have some reabsorption and we have some secretion. Okay? And so these peritubular capillaries around here, and some of them are specialized things called vasa recta that kind of just lead and follow along there. And those, you know, you have to have that association, because when we reabsorb something from the nephron, it has to go to capillaries. So remember, those capillaries are surrounding this all around it. Peritubular capillaries are also important for maintaining proper osmolarity from the cortex to the medulla. So we're going to see how they play a role in that too, primarily these that surround the nephrons. Okay, so let's talk about filtration and how the glomerulus kind of works with that. So the capillaries of the glomerulus are fenestrated. So fenestration, I always think of like fenster, like window. So they're fenestrated, so they have little holes or gaps. Okay. So they have little gaps where things can kind of move through, and they're better pictures than what I just drew. So the capillaries of the glomerulus are fenestrated, which allows large amounts of solute-rich fluid to pass. Large amounts. So they aren't like the capillary circulation that we've already talked about with the, you know, the hydrostatic pressure and moving through and then bathing the cells and then moving back in, and then you have your lymph. When we talked about that, we do have fluid moving out into the interstitial spaces, but that's much, much, much lower than we see with the glomerulus. This is much faster, much more filtration, like a sieve. So normally, this fluid is low in protein content, as proteins are too large to cross the capillary openings. Proteins and blood cells shouldn't be in there. The inner layer of the glomerular capsule contains highly modified branching epithelial cells called podocytes, and we can see pictures of those kind of on here. Podo meaning foot, so they're little foot processes that kind of surround the capillaries. They terminate in those foot processes which surround the basement membrane of the glomerulus. The clefts between the foot processes are called filtration slits. We're going to see a picture of that, or an actual like drawing of that instead of an electron microscope picture, which is also cool. So that's where they filtrate enters that the capsular space, the Bowman's capsule. So they escape from the capillary and move into the Bowman's space through those filtration slits. So the glomerulus also contains a smooth muscle-like cell that helps regulate blood flow in the glomerulus by contraction. So it kind of helps to squeeze some of that out. So let's look at these podocytes and the fenestrations. So we can kind of see how these podocytes kind of sit down there. And also the basement membrane of the capillary is supposedly negatively charged. Well, it is negatively charged. And proteins are negatively charged, so that also kind of helps push things back. Or whoops, have to go the right direction. So proteins, you know, their size excluded, but they're also kind of, you know, not really interested in even going there anyway because there's kind of a negative charge along there. So you can kind of see that smaller things are going to move through there, okay, and those are going to move into the capsule. But large proteins, not a chance. Red blood cells, really no chance, unless you start getting cellular damage. If you start getting glomerular diseases and those glomeruli break down, then that's when you're going to start seeing more proteins and blood in the urine. Okay, so that's kind of how that takes place. The podocytes form those filtration slits, and then things can kind of move through those filtration slits in the fenestrae. So glomerular filtration, so hydrostatic pressure, so a lot of this stuff we've already talked about. Hydrostatic pressure forces the fluids and the solutes through that membrane. The glomeruli and the kidney are more efficient filter than other capillary beds because well, one thing is just surface area. So many capillaries and so many of these nephrons, 1 million in each kidney or so. I don't know who counted them, but that's what everybody says. But that's a lot, and there's a lot of surface area, so you've got a lot of filtration that can happen. So you've got that 180 liters per day, as compared to 3 to 4 by other capillary beds. So let me say that again. So a point here is that if you see blood cells or protein in the urine, then there's a problem with the filtration membrane. Probably could be a problem with the filtration membrane, and it could be that there's, you know, kidney disease itself, and there's you know, a disease in the actual tubules, so that can also happen. But what happens when the capillaries break down is you have the glomerular diseases, and you can see proteins and blood in the urine. Okay, so common finding during diabetes, hypertension, that signals that kidney damage has occurred, and if untreated can progress to end-stage renal disease and renal failure. So this is a place, this glomerulus is a place that kidney disease can manifest. Okay, so let's look at some of the details. We're going to look at a couple of slides looking at this movement, this hydrostatic pressure versus this oncotic pressure. So because we have to filter things through. So we have our afferent moving in here. We've got our hydrostatic pressure. In this case, we're saying that our blood pressure is maintaining this, and our JG cells and, you know, squeezing of the afferent arteriole is maintaining that at about 65 millimeters of mercury. That's our pressure going in. We have back pressure of only 15. Okay, so fluid's going in, but it's also kind of being squeezed here, and so there's a little bit of back pressure, so 15 pushing back, and then we have the proteins that are set up in there that are also pulling those albumin, all those proteins that are stuck in there saying, no, the water, don't go, come back in. It's great, we have candy. So that's kind of pulling back, but you can see over here that only adds up to 45. So the 30 and the 15 trying to push back into the capillaries is 45, pushing out is 55. So we have a net filtration pressure of 10. Okay, so that's pretty easy math if you kind of know what all the players are. And really, we just want to know that it's a positive filtration pressure and that we have movement in, because it isn't always. And it doesn't always have to be. Okay. So we have something here. So let's see, constriction. So this is showing what happens when we constrict the afferent and the efferent, or we increase plasma proteins, and what can happen if we increase plasma proteins. That's going to decrease your GFR because you're going to have more pulling back. Okay, so this 30 could become 45, and if it becomes 45, then you've got this 30 of colloid pressure pulling back in could become 45. If it becomes 45 because we have more proteins, then we have no filtration. Okay? We're going to see an example of that later. Okay, so hopefully these things kind of make more sense. Constriction of the ureter, yeah, I guess that can kind of slow things down all the way around. But we also have this thing called filtration fraction. So that's the fraction of blood that enters the glomerulus but is filtered by the that is filtered and doesn't just move through. So earlier when we were saying, hey, if we hold all the fluid in here and we have no filtration pressure, then we're not filtering at all. So there's really no filtration factor. Okay. All right. So let's see. I think that's right. Yeah. Okay. All right, so effective capillary proteins on filtration. So this is the example that I was talking about. So if we have a normal, so we're going to say normal amount of, or typical or common or whatever you want to call that amount of proteins pulling back, and we can see that the oncotic pressure pulling back is only 19. I don't know why they use 19 instead of a nice round number, but that's what they have, and so we still have a positive filtration pressure. However, here we can see that our pressure, our hydrostatic pressure pushing in is 45, and now we have more proteins. So our oncotic pressure pulling back, or the colloidal pressure in the capillary, pulling back, it's 35, and then we have that back pressure that's always kind of there of 10, and so we have no filtration. Okay, so that's not happening. So no filtration. So what this means, so this is what I just went through. In A, protein levels are low, so you have an overall filtration movement through. In B, protein levels are high, and so you have no net filtration. So at the efferent end, so if this is our afferent arteriole, at the efferent end, what's happened is you've lost a lot of fluid. So you're losing a lot of fluid here, and you're leaving behind all those proteins. So as it moves through the glomerulus, your particle concentration is getting higher and higher and higher until you can't even push fluid out anymore. Okay? So at the efferent end of the glomerular capillary, the proteins that are left behind after most filtration has taken place increase that capillary oncotic pressure. Look at all those proteins here that were left behind. They're upset about it, and they're saying, okay, we're taking the water back. And they do. And you don't have filtration anymore. Okay, so this will have an important effect. I'm glad everybody gets along in the body. The proteins like the water likes the proteins, everybody just wants to do their thing. So this will have an important effect for exchange of substances with the nephron. So what does that mean? So that means as these proteins kind of move through here, and they're kind of left, all these proteins are left in here, makes reabsorption of water a little bit easier. Okay, so we're not there yet. We're not talking about reabsorption of water, but we do have this higher concentration of protein. Okay, and really there's a lot of stuff pulling water back into these cells. So, and we know we have to, because 180 liters of water is going through our kidneys every day, and only 1 to 2 liters gets to stay there. So we have to have a lot of reabsorption that happens all day long. Okay, so reabsorption, movement of water molecules from the tubule to the capillaries surrounding the tubules, and then secretion is movement of stuff into. So we're going to talk a little bit about what we're going to call renal clearance. We're kind of not really jumping ahead, but we're going to kind of say what's all the point of this and then we'll go back and talk details about reabsorption. So if we know what absorption is and we know what secretion is, then we can kind of, and excretion is just leaving in the urine, then we can kind of get an idea that, you know, we're saying we have to reabsorb stuff, but we're also saying that we have to, there's a nasty thing here that's moving through our blood, and we want to get rid of it. Okay, so maybe some of it is filtered through, okay, and can become urine, but maybe some of it gets by. Okay. Now, this, we may not want this to be reabsorbed, okay, but it might get reabsorbed. But if it gets by and we don't want it in our body, then hopefully maybe it gets another chance to be secreted and cleared. Okay, so what we're talking about is renal clearance. Okay, so we're trying to clear this and get it out of the body. So there are ways to do it. Filtration, and then if filtration doesn't work, we can also have secretion if that's a possibility. Okay. So same thing, different image of the same thing. We have things passing through. Okay, so toxins, and those toxins may move in here, and then we can have some. In this case, well. Okay, well these are all the possibilities, but let's kind of just pictures of the secretion versus the reabsorption. But and this is the same thing, reabsorption, secretion, just laid out in a flat line, depends on what you want to look at. But, and this is what I thought we were looking at before, but let's talk about what happens if something doesn't get filtered very well, okay? Okay, so here's substance X. That sounds a little shifty. So substance X is moving through here, and some of it is filtered. Okay, but let's say the body really doesn't want it, so there are specific, fairly specific receptors here that might cause secretion, and we have 100% clearance. Okay. All right, so that's good. So substance X didn't make it, and it's now leaving as urine. But here we have substance Y. So X seems shifty, but substance Y is tricky. And so it's reabsorbed here, but then it's like, I don't want to become urine, and so it goes back out. And only a little bit of it is secreted. Okay, so this doesn't necessarily mean toxins. Not everything is bad. But this is kind of the normal handling of certain things, like, you know, maybe urea. We're going to talk about that. And then we have, let's say substance Z, we're going to call that glucose. Okay, so here's the thing about glucose. Any sugar you eat is absorbed in your intestines, all of it, because your body likes sugar, glucose. And any that is already in your body ain't going to go anywhere. It's not going to leave. Your body keeps glucose because it's useful. So what happens to glucose is that some of it is, probably more than this actually, this was really representing glucose, but moves through with the filtrate, but then it is reabsorbed 100%. So this is 100% reabsorbed. So that's 0% clearance. Okay, so that's what we expect to see with glucose. We don't expect to see any glucose in the urine, okay, which is substance Z in this case. All right, so this is 100% clearance in this case, so none of it gets by. Most of this gets by. I don't know what the clearance is here, maybe 10%. And here we have 0% clearance. So so all of that is reabsorbed. So when we talk about renal clearance, there's a molecule called inulin where we can measure it, and we can, and the fancy thing about inulin is it is neither reabsorbed nor secreted. So the only way that inulin can leave is through filtration, and once it makes it into the nephron, it stays there and it comes out with the urine. So we can give somebody a known amount of inulin and then just monitor how much is leaving in the urine. And what does that tell us? That tells us how it tells us everything about filtration. It's not telling us anything about reabsorption or secretion because it's not reabsorbed or secreted. So if we watch this and we move through and we say, okay, so let's see, at filtration, we have 100 milliliters per minute, so that's how quickly the inulin. So what we've done is we administer this IV over 3 to 4 hours to maintain that constant level, and then we just draw samples of the plasma, the blood, and the urine to see what's going on. And so we can say, okay, it moved through here, this is how much was filtered, and 100 milliliters per minute is moving through, so that's our filtration rate right there. And since we're measuring and nothing is reabsorbed, then 100% is excreted, which means that our GFR is 100 milliliters per minute. Okay, we can only do this because, I mean, it's just moving through. Okay, so there's nothing else. I mean, it's like it's moving through at 100 milliliters per minute, so it's being produced at 100 milliliters per minute. So that means our GFR, our filtration rate, is 100 milliliters per minute because there's nothing else involved. Okay, so in this case, because there is no reabsorption or secretion, our GFR, our clearance of inulin, is our GFR. Now, there are other things like creatinine, which it's not reabsorbed much. There's not much reabsorption or secretion, so we can kind of get a good idea of GFR by measuring, like looking at creatinine. But this is actually a very accurate way to measure that. Okay. So yeah, glucose is an example of a molecule that is 100% reabsorbed, and so its clearance is 0. However, here's an example of penicillin. And penicillin is interesting because it is heavily secreted. So penicillin, it's a useful drug, but your body doesn't really want it in there. Probably because it's made from a fungus, and fungus aren't supposed to be in the body, and there are receptors over here that are going to recognize molecular patterns that are associated with fungal molecules. Okay. So, and penicillin is going to fall into that category. So the penicillin moves through, and yes, some of it is filtered, and again, our filtration rate here is 100 milliliters per minute. Good job, just like the inulin. So that's our GFR. So we're measuring, we can see that's our filtration rate. And then some of it goes past, but what happens here is like, hey, are you penicillin? You need to come with me. And the penicillin says, darn it, I almost made it, and now I'm going to be urine. Okay, so even though our filtration rate right here was 100, because it's pulling more in over here from secretion, our clearance is actually 150 milliliters per minute. Okay, so our filtration, or our clearance, is very, very high with penicillin. It is higher than our glomerular filtration rate because we have this back door, and it's throwing it in there and it's saying, hey, you can't go. And it's throwing it in there and it's saying, okay, you also need to leave with the urine. Okay, so there are things, probenecid, I think, is something that you can give with penicillin, and it'll slow that. I think it does it by competing, but it'll slow that secretion and it'll leave penicillin in the blood longer. And you know, it used to be back in World War I, whatever, that one of the wars, that when people ran out of penicillin, that it was early World War II, but anyway, that they would drink urine, okay, because all the penicillin was in the urine. Okay. And you can kind of see that. So you take penicillin, the penicillin kind of does some good, but then it ends up in urine, so they would just try to reclaim it from the urine, which makes sense. Oh yeah, and there's the probenecid. Okay, so hopefully that makes sense. All right, so now we're done, pretty much. So that's our filtration. So after filtration, things will move into the proximal convoluted tubule, and then we're going to start seeing some reabsorption, and we're going to talk about those details next. So we're going to see water moving through here. Water gets through there, glucose, urea, which is a breakdown product of proteins. Urea means it's nitrogen. And then ions, amino acids, all of those things, a lot of these things are useful and they need to be reabsorbed. So many waste molecules, but they all end up in that nephron. You shouldn't see red blood cells and you shouldn't see larger proteins present. So once something moves into that tubule, its next stop is excretion as urine unless it is reabsorbed. Okay? And that's where we'll pick up next time. Have a good day.